Alrighty, week 8 musculoskeletal pathophysiology. So skeletal muscle is the most abundant tissue in the body. Okay, blah blah blah. Okay. Blunt trauma. So when we have blunt trauma to muscle, that leads to bleeding into the muscle belly, which is normally not that big of a deal. But it can lead to potential issue of being unable to contract the muscle, and if that muscle does not get all of that crap out of there and is left in it too long and becomes really thick with calcium, then that all may coagulate and calcify, leading to myositis ossificans, which is what we can see right here with this ossified section of muscle. This should just be muscle, not bone-like tissue. The bleeding into the muscle belly can also lead to swelling and trapping of the blood in the muscle, can lead to the compartment syndrome, which we are talking about now. So this is a very dangerous complication of trauma and infection, and we can assess for it based off the 5 P's. So pain out of proportion to the injury, paralysis, paresthesia, pallor, which is just like paleness, and pulselessness. The idea is that the blood or fluid, whatever medium material is inside the limb or body in general, some compartment is expanding and filling up to the point where the skin and the muscle inside are trapping it in place, and it can't go back through the rest of the body. And so it's cutting off circulation to that part of the body, which is going to cause necrosis and death of tissue, which is what necrosis is. So we have, like, for example, edema or swelling of a tissue within a restrictive fascia. So we can see that here with this leg. This leg has something going on. Maybe there was trauma, or maybe there are some faulty valves in the veins and lymphatic system that are preventing all this fluid from going up. And so, as you can see, the skin is very tight. It's very taut. And this looks really fugly compared to this side. This is looking like it's getting very little circulation. An important note to remember with this is that we do not want to elevate the legs or arms of people who are suffering from compartment syndrome, since there's very little circulation going through this limb. If we raise it, there's going to be just that much less circulation going through this limb, leading to an increased potential for necrosis. So pathogenesis, we have some sort of edema that causes an increase in pressure in that compartment. The pressure reduces capillary blood flow, and we have the muscle and nerves becoming ischemic, leading to tissue necrosis if that pressure is not pressure is not reduced. And the damage from this can take as long as 40 weeks in total to heal from. It's not something to mess around with. So bones, we all know that stuff. Bones, type of bones. We got our cortical bones, which are on the outside, and our spongy cancellous bones on the inside, our nice epiphyseal plate right there. So osteoporosis is not the most common metabolic disease. I'm pretty certain that diabetes is. I've not been able to find anything that confirms that osteoporosis is actually the most common metabolic disease. But osteoporosis can come from a decrease in estrogen, or a decrease in calcium intake, or in disuse of those bones. And what happens is there is a rate of bone resorption which is greater than the rate of bone formation. Remember that resorption is talking about the action of parathyroid hormone, which is released by the parathyroid glands on the backside of the thyroid hormone. And the purpose of parathyroid hormone is to take calcium from the bones, break it down, and put it into the bloodstream to ensure that we have adequate levels of calcium in the bloodstream. and then calcitonin, another hormone, along with osteoblasts, are used to take calcium from the blood, put it into the bone to build bone up, which is what bone formation would be. So we have a greater rate of resorption, bringing blood or calcium into the blood, than we do taking calcium from the blood and putting it into the bones. We end up with a decrease in bone width and a decrease in bone mass. And the cancellous bone, the inside layer, is going to end up being lost more rapidly than the outside layer. The outside layer will maintain its general shape, but without this nice, thick, interwoven lattice of cancellous bone, we're going to end up with this more hollow-like tube that is at a much higher risk of fracture. So people with osteoporosis have oftentimes a shortened stature because of compression on those weakened bones. Muscle wasting from the fact that without movement, without contracting those muscles, they end up wasting over time. Back muscle spasms, difficulty bending over. As you can tell, there's very little range of motion we can get from such a disfigured spine. Difficulty bending over, and fractures. We're going to be diagnosing based off of a bone mineral density, which is used measured with dual energy X-ray absorptiometry, DXA. Okay, I gotta try it again. Absorptiometry. And they're going to score it based on standard deviations. So normal would be 0. We would want 0. And we're okay with the idea of a standard deviation of 1, negative or plus, to 0. And we have a gradation then, where if it's negative 1 to negative 2.5 standard deviations, then we're looking at osteopenia. So sort of like the beginning stages of osteoporosis. And if we get to less than or equal to negative 2.5, we're looking at osteoporosis full-blown. So the nursing implications here is that we want to get them on a healthy diet with routine exercise. So the healthy diet, we got to make sure they have plenty of calcium, vitamin D supplements if they're not getting out into the sun, or if they have problems synthesizing vitamin D. And we want to get them on routine exercise to make sure that we have enough stimulation to promote bone growth in the first place. We also may give them biphosphonates, I don't remember what those are, and recombinant human parathyroid hormone in intermittent administration. I tried looking this up. I'm not quite sure how this is beneficial because parathyroid hormone itself is going to end up promoting resorption of bone or calcium into the blood, making it so that there's even less calcium in the bones. But somehow, I guess maybe this type of human parathyroid hormone, the recombinant version, or maybe giving it intermittently, for some reason helps to build bone mass rather than resorbing it. We also want to be aware that giving glucocorticoids or anything else that might decrease bone mass may be problematic, and we may decide to not give it, or we got to weigh the benefits versus consequences of giving glucocorticoids to someone who has osteoporosis. Osteomyelitis is basically just an infection in the bone. This can come, a lot of times this can come from infected pressure ulcers, which is what this little doohickey is, I think. Yeah, oh yeah, okay. And they're exposed to pathogens that they normally would never be exposed to. We can come from burns, sinus disease, up through the, I think it's the ethmoid, or is it the sphenoid bone of the nose? I think it's it might be the ethmoid. Trauma, which opens up a bone to allow for exposure. Tumor necrosis, periodontal infection, an open fracture or a penetrating wound. Lots of things. Anything where the bone itself is exposed to the environment that it normally wouldn't be, we have a risk for infection. So most of the time, it is done through a hematogenous um, infection, where we have an infectious agent that is introduced by blood from an infection elsewhere. So they had sepsis. That sepsis then has led to the exposure of blood to the agent via the blood via circulation. Normally, this is only going to be to those who are really young or really old, and S. aureus is going to be the most common pathogen there. In children, this is going to present as a high fever and pain at the site of the bone involvement, pretty basic symptoms. For adults, it may be a little less specific. They're going to have fever, malaise, anorexia. They're not going to eat, night sweats, weight loss. It might be more difficult to observe in adults. There are some complications for this as well, and I don't really understand exactly whether Brody's abscess actually is an incomplete or untreated osteomyelitis, because from what I saw, Brody's abscess is actually a subacute or a chronic osteomyelitis, comes on as an insidious onset and is kind of captured by bone scarring, scar tissue in the bone around that joint or around that spot to prevent it from getting worse. It does require debridement to remove a Brody's abscess, and I think it is a necrotic cavity. I don't know. Just know that you can get a Brody's abscess, and that requires debridement, and it is a form of osteomyelitis. They may require also antibiotic therapy to help to reduce if it's S. aureus, to get rid of S. aureus. Pain management, these may be very painful in the first place. If it's really, really bad and there's not much of a chance of being able to salvage the limb, then they may have to resort to amputation. So a fracture is a break in a bone, it's a broken leg or arm or whatever. It can also occur at the epiphyseal plate or at cartilaginous surfaces. And of course, we're likely to be experiencing some trauma to adjacent tissue if we're talking about like a compound flat fracture or some other kind of fracture that's more significantly traumatic. Okay, so we have several classifications. We can have transverse. Let's see, do I have the picture over there? Yeah. So we got our transverse fracture here, so that's just being straight across. Spiral, where it kind of wraps around the bone as it goes up. Longitudinal, where it runs the length of the bone. Oblique, which is just straight across, not spiraling around the long bone. Comminuted is going to be where it breaks off into a bunch of little bones. These are a pain in the butt to fix. Impact is where one side goes and runs into another, so someone jumps off a building and they try to land on their legs. That would be potentially an impacted fracture. Green stick is going to be common with children, and that's going to be where a section kind of splits off like a green stick would. A stress fracture is an incomplete fracture, but it's the start of one. And then an involsion or avulsion is going to be more specific to the patella, where we have a piece broken off like this. So we have the orientation, which is going to be the shapes there, and comminuted is going to be where we have a fracture line that is more than one fracture line and results in more than two fragments. I thought there was more to it than that. Yeah, okay. Okay. And then we can also divide it into being either a complete or an incomplete fracture. So we could have, this would be like a complete fracture where this is the entire length of the bone right here. And this fracture goes through and creates two separate pieces of bone. Incomplete is going to be where we have the bone is still joined to the remaining piece of bone, but there is a break, a fracture through part of the bone. So, for example, we could say we have a complete transverse fracture. There's also another piece, I think. Okay, here we go. We can also say whether it is displaced and whether it is closed or open. So this would be a open or compound fracture, and this one would be a closed fracture. This one would be a non-displaced fracture since it's still in alignment. This one would be a displaced and opened fracture. So these can each be their own individual classifications. So is there an example here? No, there's not. So let's say we had, I think this one would be a non-displaced, closed, complete transverse fracture. This one would be a displaced, open, complete transverse fracture. Hopefully that makes sense. There's a lot kind of classifications you can apply to it. A depressed fracture can also be to, like for example, the skull, and it can also be to long bones as well, where there's a fragment of the bone that's been displaced or pushed below the normal bone surface. So you smack someone in the head with a crowbar, you might end up with a depressed fracture. So with the healing process, when you have a fracture, this is the general simplified version of what bones go through after they experience a fracture. So we have the torn blood vessels here that leads to a clot formation being made. From there, all of this is going to be clotting and forming into this fibrocartilaginous callus. And this is a soft form of a callus. This is formed pretty early on. But over time, this fibrocartilaginous callus is going to transition into a spongy bone callus, or a hard callus. This is still kind of weak right here. This is not fully formed combination of callus bone and cortical bone, cancellous bone and cortical bone. This is mostly right now cancellous bone. And here we have our fully healed bone with both cancellous and cortical bone tissue representing. So remodeling is going to be where we have the actual replacement of the bone with mature, or replacement of the cartilaginous tissue with mature bone. So that'd be here. Let's see here, am I missing anything? When we have a cancellous fracture, so just a fracture within the bone, not using the cortical outside of the bone, we're going to develop an internal callus that heals more quickly than cortical bone. This is partially also because we have such a good stabilized section to control the bone, because the cortical bone is not broken, and because we have a rich blood supply, and that rich blood supply also helps to prevent necrosis because we're kind of trapping that environment from exposure. And it's completely healed when the mature bone has replaced the callus. So when we have a fracture, the goal is to reduce and immobilize that fracture. We're going to give them ice and elevation, though I've heard some arguments against ice from the perspective that the bone or the body's natural inflammatory response helps to further sort of stabilize the joint, but that's still up for debate. If we have an opened fracture, we're going to give antibiotics and tetanus because they're at high risk for infection, super high risk for infection. Give them pain medication, and then over time rehabilitation of soft tissue and muscles to help renew the functional ability of that joint. The muscles are likely to atrophy over time, which is normal, but we want to try to limit how much that occurs. We can have some complications in the healing process of bones, fractures. So if we have a delayed union over 3 to 6 months, we can have a delayed union where it takes longer for the union for the two ends of the bones to unite together. which can result as well in some malformation of the bones joining. We can have a malunion in itself where the bones are not properly aligned, leading to structural and functional issues in how that joint is used. And you can have also a non-union if it has not healed by more than 6 months. So if it's 3 to 6 months that it hasn't healed, that would be delayed union. But then there's a non-union if it's been more than 6 months and it's still not fully healed. So we can have death of bone tissue as well as osteonecrosis, which can occur as a result of osteomyelitis, or there's a complete lack of blood supply to the bone. Then that bone tissue will start to become necrotic. I don't know what that's supposed to say. There are a number of things that can impair our ability to heal bone. If we have a person who is older or has decreased mobility, they're not going to have as much stimuli or natural resources to promote bone healing. Smoking also tends to impair bone healing, as does poor nutritional status, like not having enough calcium or not enough vitamin D, or if they use alcohol, which is going to reduce their nutritional status. If they have a decrease in immunity, they're going to be more susceptible to infection from having a broken bone, which would also impair bone healing. Certain medications, like glucocorticoids, might be something that can impair bone healing as well. And then, of course, if we have infection or a decrease in vascular supply, we're not going to have, well, this is going to distract the body from healing the bone. And then this is not going to have the resources to allow for the body to provide stuff to the bone's fracture area to allow for healing. Compartment syndrome is a distinct issue that can occur with someone who has broken a limb, because when we have this super rigid, tight cast around a leg or an arm, and maybe there's fluid inside that's accumulating, there's a little bit of a bleed that people were not expecting. Any expanse of the tissue there has an increased risk of closing off circulation. So one of the things that we're going to be doing with anyone who's got a cast on as a patient, we're going to do checks up here. We're going to look at the tissue color and find out, is it pale, is it mottled, is it normal pink, what is the cap refill like on the toe, do we have sensation, do we have pulses. You can kind of put your finger down here a little bit and maybe feel the the pedal pulse. What is this one called? Can't remember. But the pulse right here on the top between the big toe and the second toe. With joint trauma with fractures, we can also develop a deep vein thrombosis or pulmonary embolism. Oftentimes these will, whether it's those forms or the fat emboli, these can be a sort of delayed response, and it'll present with chest pain, dyspnea, hypoxia, or hypoxemia more than 5 days after a fracture. Kind of takes a little while for the clot to develop and then break off and travel. Those who have multiple trauma or prolonged immobility, like someone who was in a really serious car accident and had to be put into a coma, super high risk for a DVT and a PE. And we're going to prevent this by providing them with anticoagulation prophylaxis, but we want to make sure that it is the right amount because we don't want them to bleed out from the trauma. We may also provide them intermittent pneumatic compression devices to try to keep the blood flowing, but I mean, of course, if you've got someone with a cast on their lower leg, there might be some barriers to that. We also want to encourage early mobilization to keep the blood flowing, the muscles contracting, the blood pumping up through the veins, and keeping everything all nice and groovy. Fat emboli syndrome is something much more specific. It is the same kind of idea in that we get an emboli that travels around, or a thrombus that travels around, or I guess the emboli travels. I can't remember now. So we get this fat that comes out because fat is released every time we have a bone fracture of some kind. And when it gets released, it may go and it traps blood in multiple different areas. So they could have chest pain if it traps inside the lungs or the heart, along with dyspnea and hypoxemia, tachypnea. We may end up, and supposedly this is actually a pretty common sign, a fine petechial rash over the torso and the neck area. I tried looking into that, and no one can really. There's some theories behind the idea, but there's no real distinctive or definitive answer as to why that occurs. And there's a good chance also they may experience an altered mental status. So when it comes to implications for fractures, children are at risk of having their epiphyseal plate fractured. It's a weakened spot. It's not fully developed yet, and when they have a fracture, that needs to be confirmed and checked into more readily than with adults, because if it's not treated appropriately, that can result in growth dysfunction. They have like a shorter limb than the other limb, or disfigurement in that the bone actually grows in a different direction than it should, and may actually present with some mobility or functional impairment. We want to educate and look for signs and symptoms of delayed healing. So if there's not been proper union through way of x-ray, or if there's been a lack of proper nutrition going into the body, then that may lead to delayed healing. If we have emergent complications, we want to be aware of those. So we look out for things like, do they have any breathing concerns? Are they starting to breathe a little bit more fast or deeper than they normally were? Are they kind of sitting awkwardly because they're a little bit uncomfortable? We want to check always the pulses, perfusion, and cast care to make sure that nothing gets in the way of healing. So arthritis or osteoarthritis is a very common age-associated condition that comes just from regular wear and tear of joints. There's just simply the local degenerative weight-bearing joints that are affected, like in the hips. There is local and degenerative impacts to weight-bearing joints, like the hips, the knees, cervical and lumbosacral area. They generally experience stiffness upon waking, or if they've been through long periods of inactivity, which occurs a lot more often as you get older. And they may have pain during or after activity. Now, there's a difference between osteoarthritis and rheumatoid arthritis. Osteoarthritis is simply where we're going to have thinned cartilage that results in bone ends rubbing together. Get my pen back. So the bone ends rub together because of thin cartilage. With rheumatoid arthritis, the synovial joint around the joint, or the synovial capsule around the joint itself, has that autoantibody complexes inside that are destroying and inflaming the joint, and it ends up with bone erosion as well as a swollen and inflamed synovial membrane. There are lots of risk factors for osteoarthritis, a lot of which is with regard to how we lived our life, such as if we've had multiple injuries, occupational hazards. It is something that comes along with aging, genetics. I think there's some debate over whether obesity actually has an impact on it. It might, but I think there's still some arguments. Being female because of hormones, a lot of things can impact it. Most people will end up having, or a lot of people end up having osteoarthritis as they age.